a little bit about you and your journey in medicine.
I applied to emergency medicine residency on a family practice rotation that I thought I was going in that direction. The doc, there were a couple days that she wasn't working, so she dropped me off at the emergency department. And the notion is, which kind of became like the night destination for my book, is when I finally became an attending in emergency medicine. Some of the themes of your podcast are these little obstacles and failures that come along the way. So I did not match, and I thought the world was ending. People were not taking gap years or taking time out from charging in. This was the early 80s. So I ended up doing a second PGY 1 year at a local hospital.
Welcome, everyone. My name is Dr. Moss from Life as a Patient Doctor. I am very excited and honored to interview Dr. Joan Naidorf, who is a board-certified emergency medicine physician with over 30 years practicing in hospitals in Northern Virginia. Her book, Changing How We Think About Difficult Patients, a guide for physicians and healthcare professionals, was published in 2022 and is widely available in electronic, paperback, and audio formats. In addition to her book reviews and opinion pieces that have been widely circulated in both the Washington Post, the DO, and Doc70. After hours, she likes to travel, read, play tennis, follow Dolly the poodle, and walk along the Virginia beach. Thank you for being here today.
Really happy to be here talking to you.
Yes, I know we mentioned so many great things right before I start recording, so let's just slow down, back it up. Tell me a little bit about you and your journey in medicine.
Yeah, I grew up in central New Jersey, and I got a notion that I was interested in medicine. I think my dad encouraged me quite a bit. He wanted to be a physician. He was an optometrist, and it wasn't going to happen with any of my siblings. The only person it was going to happen with was me. And I started doing some volunteering, and I as a candy striper in the hospital, actually, and started getting that bug that this was something that I really wanted to do. I wanted to devote myself to help people get better, help sick people get better, help them feel better. I ended up going from central New Jersey to the University of Virginia. And I did meet my husband there. We got married later, but we were undergraduate students. From UVA, I got into Philadelphia College of Osteopathic Medicine. That was my path to become a physician. And I didn't know that much about osteopathic medicine when I started, but I did know that the people around me were really highly motivated, very interesting students, great people. The teachers we had in Philadelphia were people who had come and gone and were teaching at the other medical schools in the city. So I knew that we were having a top-notch education. I think some of our clinical rotations were structured differently at that time, being at community hospitals and not at teaching hospitals. So I think that was different. And then most of us would go on to a rotating internship our first year out. And I did that. I was in Northeast Philadelphia. And then I applied to a family practice rotation that I thought I was going in that direction. The doc, there were a couple days that she wasn't working, so she dropped me off at the emergency department at this local hospital. And I'm like, what? This is the best thing ever. And for me, it was this challenge of figuring out what was going on with people, getting a chance to not only go through this intellectual exercise, but all the procedures that we get to do that are so much fun, and we get the best toys to play with too.
Love that.
And then the best thing at the end is totally different every day, totally different set of characters, patient problems, elderly people, pregnant people, children, the whole gamut, everything we get. And then at the end, we get to say goodbye to them, which I think is the best thing of all. And I know that some of our colleagues, and I'm so grateful that they love this, to have long-term relationships with their patients. But our goal in emergency medicine is to just see someone once or twice, or if they're in our community, they come back, of course, but we want these kind of short-term relationships with them.
That's a really good point. I'm glad you mentioned that. So I'm guessing in that sense, you're really trying to develop really good rapport, or really getting the information quickly is, I'm sure, very important.
Absolutely. And then the notion is, which kind of became like the origination for my book, is when I finally became an attending in emergency medicine. What I was going to say, which some of the themes of your podcast are these little obstacles and failures that come along the way. So I did not match the first time. And I had a very messy morning, sobbing in the shower when I found out I didn't match. and I thought the world was ending. And people were not taking gap years or taking time out from charging in. This was the early 80s. So I ended up doing a second PGY 1 year at a local hospital, happened to be where my husband was practicing, Albert Einstein Medical Center in North Philadelphia. It's a really great hospital. And I got a lot of really valuable training, had to do a lot of call. It was another PGY 1 year. I was an intern 2 years in a row. But when I reapplied for the residency that I finally got into, emergency medicine, which is actually now based at Albert Einstein, I was able to get in there. And at that time, it was very difficult to get into emergency medicine residencies. It was really a new profession. And it actually originated at the hospital where I started my first job, which was like a dedicated group of physicians staffed the emergency department who did not have a practice outside of the hospital.
Huh.
And then the residency programs originated to teach people how to do that better, and with emphasis on resuscitation and emergencies, burn care, all the things that we have to deal with. And so when I came out, there were, I want to say, maybe like 300 physicians in the whole country that were training emergency physicians. And now there are, of course, lots more, like maybe 5,000 of them.
Huh. I can't imagine what was going on with if emergency medicine. Are you saying it didn't exist as a training, or how would people train if it didn't exist?
Okay, so that's a good question. I know, like, it probably seems inconceivable to you now.
It does.
For a patient to be seen after hours in the hospital, they would show up, and there was something called an emergency room, which probably was a room. Now we call it the emergency department because it's possibly, in my opinion, the most important department in the hospital, my humble opinion. And it was mostly staffed at that time by physicians who were either internists or general practitioners who were moonlighting from setting up their own practices to do a couple shifts, like to earn extra money. And I think some people decided that was a good place to be based, and they wanted to do that full time. And they did this called the Alexandria Plan at Alexandria Hospital in Alexandria, Virginia. And then the residency programs grew after that. It's a relatively new specialty. People were not trained just to do that. And when I came out, people would ask me, what were you trained to do? I'm like, I'm actually trained to do this. So it's been very interesting to watch over the decades and become very popular specialty. I think we've had our ups and downs. There are probably reasons for that. I'm not an expert, but I have some opinions. And I think that the changes, the hospitals have made it so that it's very hard for people who are not trained and board certified in emergency medicine to be practicing in emergency departments. Now, clearly some of our colleagues who are perhaps trained in internal medicine or surgery, they have really fantastic skills. And then over the years, they accumulate all the skills that are necessary for the emergency department. But a lot of hospitals will only credential people on their staffs who are residency trained.
Yeah, no, thank you so much for sharing kind of that journey and how cool I can imagine now watching all that going from people not putting the emphasis to it is the most important, especially we're talking about the recent pandemic where they brought everyone into the emergency room to help staff because it needed that triage. So, wow, how amazing to be able to look back and see that transition of...
At one time, patients would be sent in from doctors' offices, sometimes with a set of admission orders, and just sent to the admissions office of a hospital and go up to a room. That almost doesn't happen nowadays. There would be no urgency or way for people to get an IV started and get bloods drawn, and bloods were not sent off stat from the floor. They're just like, okay, you put the labs in and you get the stuff the next morning. You have to show a much higher level of need to even be admitted to the hospital. So people are naturally processed and seen and evaluated in the emergency department because we have access to all the labs and the imaging and the procedures that we need. And we can usually do them in the first 4 to 6 hours and usually decide if someone needs to be admitted, where they need to be admitted to, or if they could potentially be sent home with treatment. So it's really important. But years ago, doctors in the office also took care of patients in the hospital. And so they had all this stuff going on in the hospital. And then over the years, so much more that had to be done in their offices and then in the hospital that now they're hospital-based physicians, hospitalists. So the way I tell it is that people would come in and be seen by the first hospitalist, who is the emergency physician, and then be handed over to the second hospitalist, who's the hospital-based physician. And then most people are never even seen by their own primary care providers when they're in the hospital. So it's much more, the process is not as, in some ways, not as great for physicians because they don't know who's taking care of them. The people are total strangers to them, but they do get people who are right there at the bedside or in the hospital and available to them right away.
Yeah, like you said, it's changed so much. I know that family medicine is pretty much the closest we have that they still, at least in training, that they do a little, mostly outpatient, and then they sometimes get to follow them as internists. And then OB-GYN also residents do a little bit of sometimes seeing their same OB-GYN delivering the patient. But yeah, it definitely has changed. I want to go back. You did mention, I want to thank you so much for being open and vulnerable about your challenge with getting into medical school, getting into the residency of your choice. Because like you said, it's something that isn't talked about a lot and is something that did exist, even like it does exist out there. And it doesn't, just because people talk about it doesn't mean that it doesn't happen. And so,
yeah, it's very difficult, especially if there's something tying you to a geographic place or a person. Like my husband and I went to separate medical schools. We were not engaged then, and I got in Philadelphia and he got into Eastern Virginia Medical School, which was in Norfolk. And then at that time, his school was 3 years and he came to Philadelphia. And then I wanted to stay in Philadelphia. So I was applying. It was a great city to be looking for medical education, probably a lot like Chicago. There are a lot of options. But even still, there were only, I think, 3 emergency medicine residency programs available at the time. There were only 6 spots in one and maybe 10 in another. There weren't many options and a lot of people applying. It's hard to think about what your plan B is going to be, but you have to set something up. In retrospect, that day I thought it was the end of the world. It actually made me a much better doctor. I had a much better understanding of how to deal with internal medicine patients, which are a major part of what we're seeing in the emergency department. And I could get some really good perspective. So I felt really comfortable with that. And I think anytime you get extra training and more time helps put things in perspective for you.
Very much. I agree. And I think that is why a lot of times some residencies require that first year to be a lot of internal medicine. Even if you're not going to do that for the rest of your life, it does provide such a valuable toolkit to pull from. And I do want to say, I'm so glad that you mentioned of the difficulty of trying to stay in a specific geographic location or to stay with a support system. It's a reality, and it's something I was very lucky, but because my husband was in Chicago for his residency, and then so when I applied, I tried to only apply to that area, but there was a very good chance of I couldn't have matched and I would have been in trouble. And so I would have to go to my plan B or C. But yeah, it's a really hard situation when you're trying to balance those key things. So then looking forward, so I'm guessing it was 3 years of emergency room?
Well, at the time, some of my colleagues were doing 3 years. It was 2 years after a rotating internship, but then I had done an extra year. So I was in training for 4 years. So like that was enough. I was ready to start. And what was interesting, and my husband, by some kind of little miracle, he was also finishing his GI fellowship at the same time I was finishing my emergency medicine residency.
Oh, perfect.
And we decided to move. I got a job at Alexandria Hospital, and he decided he was going to start a solo practice. But it went pretty well for him for a while. Now works with a hospital-based group. But what I discovered when I became an attending, and I think that this is something, a little piece of reality that some of your fellow students, people are noticing when they hit the floors for the first time, clinical medicine, this kind of idealized view of what we think patient care is going to be. Turns out to be disappointing.
Hmm.
And the main thing, one of the things that we find disappointing, there are a lot of things in our system that are troubling, but a problem that I felt I was having was some of the interactions with people that were really difficult, very challenging. And even though I was probably having a really good day, say seeing 20, 25 patients, and most of them went great and we had happy endings and they left happy and shook my hand and thanked me, but still there's some arguments and confrontations and stuff going on. And so at the end of the day, you feel like it was terrible, even though it really wasn't. So at the time, I was on the associate clinical faculty at George Washington University, and I put together a presentation on dealing with difficult patients. And I gave it, and the crux of it was we need to have these interactions. We can't just say, hit the road. Some of my articles that I've written, some of the doctors will say, just fire them from your practice. I'm like, we're in the emergency department. We can't do that. Just because someone acts like a jerk, we still have to do a medical stabilization evaluation and treat them and do our best, even though their behavior is not good. I gave a lecture for grand rounds. My department chair loved it, and I ended up giving it the second year, and I put it aside and I learned a lot from it. I did it better. Didn't do it perfectly because it's really hard to do. And I put it aside. And then when I retired from clinical practice, I decided I would pick that up again and teach it to residents. So I started doing that at the beginning of COVID, and we were doing some remote learning and I was doing some virtual conferences. By the way, anybody who's listening, I'd be happy to give the conference for your residency programs.
Yes.
Contact me. And I had learned some ideas from cognitive behavioral therapy about changing thoughts. So a large portion, what I discovered was our colleagues, the nurses, respiratory therapists, EMTs, our fellow physicians, we have been taught and propagate a very negative view of our patients. And we're calling them names. We're talking trash about them in the nurses' station and in the break rooms. And that all stems from these kind of negative thoughts and wishing that they would behave a certain way, follow our advice, follow our recommendations, stop smoking, stop taking drugs, all the things that we wish they would do, but they just can't do it. And for one reason or another. And if we could change the way we think about them and be more accepting, that we would get better, we would feel better about it, and we would get better results. And us getting better results is better results for our patients. So I decided to write a book. And one of my girlfriends from my residency program suggested that I write the book. And I followed the idea and focused to write a chapter a week. So it took me about 3 or 4 months.
Good for writing a book.
I had the outline of it already from the lecture and some of the research that I done. I wasn't doing research on patients, but I was just doing what was out there in the literature. And 30 years ago, there wasn't very much. And the first talk about James Grove's classic article and he was a psychiatrist at Mass General, and he wrote a special article called about taking care of the hateful patient. And this is the first time that kind of literature we could admit that doctors didn't like some of their patients. We had this kind of omnipotent view, and that we could just kind of handle everything and nothing bothered us. But in reality, we know that's not true. And what Dr. Groves talked about was recognizing some of these stereotypical patients. He talks about 4 different types, and I talk about it in the book and expand it, what the patients are going through, what the professionals are going through. And with a lot more understanding of what we're going through, we can change the way that we're thinking about them. So I did get the story about how it was published is a pretty good one. I was actually talking on another podcast about something else. It was something at the beginning of COVID and something I wanted to talk about. I think it was on Kevin Poe from Kevin MD. And I asked him who published his book and gave me the name. I sent the manuscript to her and she gave me a contract to publish the book, which is not usually how it goes.
Oh my goodness, congratulations.
Thank you.
I love that. That was also, I was on Dr. Poe's podcast a couple times. So that is a really cool transition. And networking is so important. And that's how you make those connections. But everything that you just said, I kept thinking about just the concept of humanizing patients. And I think that is something that was very emphasized in my medical school training. And through learning about the history of medicine, it seems to be relatively new concept. The learning about the social determinants of health, learning about people being people and instead of just, oh, they don't want to take their medication. They're looking at someone who is a substance user as a bad person, or they're doing it to try to spite us. No, there's a whole global system around every single patient. And I'm thinking that's what you are talking about. And you were like the spearheader of that in the medical education world, really starting to see people as people.
It is difficult because we are, again, literally taught this kind of thinking from our senior residents, using names for patients. I don't even mean sometimes bad names like dirtball. One of the professors used the term toad, totally obnoxious alcoholic derelict. And that's what we were calling people. And they thought it was just uproariously funny. And it's very demeaning, or just even calling someone the cancer patient or the alcoholic or the druggie or something like that. We use these kind of names all the time because we don't take the time. For one thing, we don't want to identify people by their actual names because of HIPAA stuff. Or we just say, in the emergency department, we say something like the lady in bed 10 because everybody knows what that is. So it's not always, we fell into this naturally. And it happens so frequently that some of us are not even aware of how dehumanizing it is. So I think I'm trying to call people's attention to that. And the only way to actually change your thoughts about, like, just even using the labels is to become more aware that you're doing it.
Yes, that is definitely the first step of changing. We're talking about a cultural change. And because like you said, you learn this from being in an environment where your leaders, your senior residents, you're just doing what was taught and what the culture was. And so going against the grain is difficult, even though sometimes it goes against your ethical. I talked to someone recently that I interviewed about the moral dilemma and how that can impact medical students and residents and even attendings of when you're seeing things that go against your own values, but you have to keep going because if not, you won't be able to see the patients and just get through the day. And I think you talked a little bit about how burnout is impacted. Can you speak a little bit about that, where the connection is?
Burnout, I think, is one little part of it. With burnout, people are getting cynical and exhausted, and they don't see the value in what they're doing anymore. So I feel like there are a lot of obstacles that people are coming upon in their practice, like they can't get insurance companies to approve things, or they can't get certain studies quickly or at all. And so that is very frustrating. But one thing we can do is lean in and find out why our patients aren't taking their medicines. How come they can't get to a dialysis appointment that they're supposed to make every week or multiple times a week, and they end up showing up in the emergency department instead in extremis? And if we could just find out the reason, instead of just writing on their chart, non-compliant, that's another label that like torpedoes people. When the notes that you read on a triage form written by one of the nurses or a prior note written by one of our colleagues can just absolutely change the way you think about a patient, because we work under confirmation bias. If we're going to look for something, this idea that this is a non-compliant patient, that's all we see is the way that they're not complying with the medications or follow-up appointments or stuff like that, instead of like the 98% of their behavior, which actually is adhering to the plan. So there are very subtle ways that we can change our language, and it can also help change the way we think about our patients. When we have more empathy and more compassion, we come up with better solutions. We come up with some ideas that can help the patients solve their problems with access. We have resources available But if we don't know that Mrs. Jones can't get a ride to her dialysis appointment, or she can't get her medicine because it's not covered or something like that, we have resources to use, but we can't use them unless we know about them. And to know about them, we have to lean in and ask.
I love that, leaning in. I think that is so important. And it reminded me a lot of what I have to deal with as a psychiatry resident, is the struggle of individuals when they just see, oh, this person has some type of mental health thing. Maybe they see bipolar. And so they're like, oh, anything that this person is going to deal with is going to only be their mental health. This patient can't have appendicitis. This patient cannot have high blood pressure. It's all only because of the mental health. And that's not the case. People are people.
Yeah. So people with bipolar disorder have appendicitis, and there's so many biases. This is part of what I don't talk about this part as much because maybe I'm not the right person to be addressing this, but part of this, how we view patients and their difficulties, has to do with our own personal biases. And we all have biases. And I talk a little bit in the book about bias against obese patients and how everything is written off by their body weight and their BMI. And it also takes place with people who have some sort of mental health disorder, because we say, or illness, that everything is due to that underlying thing, when our patients can have more than one diagnosis or thing going on at the same time. That is totally clear, and we can't forget about that. What's really difficult about what I found in the emergency department with psychiatric patients, for one thing, a lot of them are underdiagnosed or undertreated. And then some of them, when they're feeling good, they think they don't need their medicines. Of course, the only reason they're feeling good is because they were taking their medicines for a while. It's really hard to reason that with someone when they're not thinking straight. I know you haven't had a chance to really read the book, but you will. Psychiatric patients are a really big category of people who can be difficult sometimes.
You know what? That is actually why I love them so much. And that's why I went into that specialty, because whenever someone said, oh, that's a difficult patient, I would just go, I'm like, ooh, challenge. I want to see if I can reach them on a human level that maybe my colleagues weren't able to. And so for me, I love it, but it's because of that ability, just seeing people as humans instead of just of a single diagnosis or whatever biases have been placed on them. Even my own bias, it's important to constantly we talk about this a lot in residency, constantly examining our own biases and how they're impacting how we're interacting or thinking about the patient. But thank you. Whew, we've talked about so many amazing things, and I will make sure that your link to your book is below. I'll make sure. I liked that you mentioned taking care of the hateful patient with Dr. Grove. I'm going to look up that.
That is from the New England Journal of Medicine. So the original is behind a paywall. However, it was reprinted through Washington University of St. Louis, so it is widely accessible. It really was one of these landmark articles that kind of changed everything. And then there was a lot of response to that over the years. And I think it's another generation now, and we need to be reminded of it. We need to be reminded what the lesson was, is if you're feeling some sort of negative emotion, like you're angry or frustrated or disgusted or feeling defeated, something's going on that you need to get a handle on. And you can change your thoughts about that. Some of our patients are going to die, even if we're doing the right thing. And we need to be able to accept that. It's really hard to accept it. And I think everybody agrees that there are times it's really appropriate to be sad, and it's really appropriate to cry. And we need to take the time to feel those emotions. So I think in years past, residents were taught, suck it up and get back to the next person because someone else is waiting for you. And that's true to some extent, but at least now we know we have a little bit more debriefing. People are encouraged or allowed to feel their emotions, because some of it is just heartbreakingly sad.
Thank you for saying that. It definitely motivates me to bring that article out, and at least for my residents, it sounds like a great thing to, like you said, bring it back in, because it's so important. And if it was a landmark article, everyone always loves those, to make sure that those are mentioned. So I'm going to do a quick summary of all the amazing things you said. So you started off by just talking about how You started off in New Jersey. New Jersey, your dad was an optometrist. You were interested in medicine, but didn't really know a lot of what it meant. And then you were a candy striper in the hospital, and you're like, this is mine. You met your husband in undergrad, but separated, went to med school, went to different programs, but were able to reconnect a little later while you were in residency. There were a little bumps in the road of being challenged getting into your first year of emergency medicine, but we're eventually able to do that as one of the original emergency medicine residents in the nation. And you really got to see the whole transition in medicine in the United States of how it went from kind of people being a direct admit to the hospital to people actually going into a set emergency room or department before actually going up to the hospital if they need to stay or if they need to go. You also talked about your motivation to start writing your book, and it started off by just doing a grand rounds about talking about a difficult patient, and people were interested in it. And even though you didn't touch on that until a lot later when you retired, that concept was still in your mind, and it has been so important of looking back at all the patients and how medicine really works, of how sometimes we can be very negative, of how the culture of medicine is very negative against patients. They're very separate. Patients over here, doctors over here. And you talked about how important it is to lean into why patients are struggling. See, okay, not just using a term like non-compliant, like actually understand what is going on and bringing that empathy and compassion to go against the biases that we are sometimes are very prominent in medicine. So I thank you so much for sharing your journey. Where can people get your book? Show us your book.
The book,
There it is.
Changing How We Think About Difficult Patients. It's very short. It's got some really cool artwork in it, actually. That's called Continuous Contour Line Drawing.
Ooh, cool.
Available. It was published by the American Association for Physician Leadership. It's available through their website and also available through all the major places that you get books, Amazon, Barnes and Noble. I've seen it on Target and Walmart and all those sort of places. It's also available. It's available as an ebook, and it also is available as an audiobook, which
I was going to ask.
I did not narrate it. And it's a professional voice actor, a female, narrated it. So she's good. I also took the liberty, I wrote about this recently because I write a lot of opinion pieces in various other places about taking over the profession. We're going to be taking over the profession. Women are going to be taking over this profession. It was always a very patriarchal system where you just did what the patriarchal male physician suggested. But now we're trying to bring in what our patients desire and have it be collaborative. And so when I refer to a generic physician in the book, I always use the pronoun she. It's my book. I'll do what I want.
Yes, and that is so important. We could talk about this forever, of medicine being very patriarchal of the culture. And yes, it is little by little, we change. Even if it takes multiple generations, we're getting.
The other day was National Women's Physicians Day. It's the birthday of Elizabeth Blackwell. One of the books I review books for the DO magazine, as one of her biographies. Really good book. And it was very hard for her to break in, very hard for her to find somewhere to train. And now more than half of medical students in the country are women.
Yeah, I think it was on Monday. I think it was 55% that AMWA reported. Thank you so much for sharing that. I'm going to put the audiobook on my to-do list because I drive to residency, so that's how I can get a lot of my reading in.
It's under 4 hours running time. Under 4 hours. It's not a very long book. And I will tell a very sweet guy that I sent it to at the beginning told me that before he would go into a shift in the emergency department, that he would read one of the chapters. It's like a self-help book for physicians and nurses and residents and medical students. And not that there's a category of that on the bookshelf somewhere, but I think it's what we need.
It very much is needed. I love that. And I'm going to be having to reach out to you because that is on my next to-do list in the future is to, because so many people have been saying, why don't you write a book with how many blog posts and just like you, I'm going in your footsteps, all the writing. So I also
think,
am a fellow. So I've also written for docs. I write for
yeah,
docs.
I think that the writing that you do becomes like your resume. And someday you can pull different chapters and make a book out of it. And a lot of writers do that. That isn't exactly the way I did it, but some of the lessons that I've learned, I've used some little chapters and written, broken out little articles to publish somewhere. But I very much want to spread the idea, the message. Like, if people want to buy the book, that's fine because it helps go in more in depth. But I'm like, next Monday, I'm talking to, hopefully it's not going to snow too much. I'm driving up to Bethesda and talking to a group of family practice residents at a hospital up there. That's been fun, going to some different places. And I wrote an article about talking at a children's rehab hospital in New York City. Maybe if you can put the link to my website, which has articles and stuff like that, that would be really nice.
That was my next question to
Yeah.
ask you is how can people get in contact with you or get more information on all this amazing stuff you wrote?
So it's drjoannadorf.com, and there's a contact sheet on there that actually does work and comes to me, and I respond to all these things. I'm a staff of one. It's me and Dolly the poodle. So I have fun doing it, and if I can help people, I've done a number of podcasts. I've done a number of just like drop in for meetings, and a lot of people turn to me, possibly like yourself, for mentoring about writing and writing books, because that kind of makes, like, I'm not saying that I am an expert, but people look at you and say you have a book, so you're an expert.
Yes, you're an expert if you say you're an expert.
A couple years ago, on one of the social media, I started following people on social media platform and told them that I would read their essays for medical school, for either medical school or for residency. And not that I know anything about that, but I know how to write a good essay or tell a good story.
That is important.
A lot of people come to me and send me their books to either blurb them or to see if I'll review them. And it's not just up to me about reviewing books for the magazine, but I do have some say. And there's some books that I've loved and some books that I haven't loved.
Amazing. Thank you, Dr. Naidorf. I'll definitely be contacting you
in the future. You got a lot of work to do when you're a resident. And
thank you. Yes, and I'll make sure that those links to your website and your book are below so we can all learn from you. I appreciate Dr. Naidorf for taking the time today to speak with me and our listeners. If any of the listeners want to see some of the writing that I've done, I try to keep them all on my website at medpsychmoss.com, and you can click on the work, and that's where all of them are linked. I talked about the Doximity post, so you can see some of the Doximity articles, and when I've been on Dr. Kevin and because we both talked about. So I'll see if I can get some of those articles that both of us have written. And you can follow me on social media. And if you haven't already, make sure you are subscribed, whether it's on YouTube or wherever you get your podcasts. Thank you all so much. And I appreciate you taking the time, Dr. Naidorf.